across 22 countries, across different age groups, across different income strata, taking into account poverty and all of these other issues, inequality still matters. Had we had lower inequality, what our model basically says is that we would have had lower mortality.
The Rational View is a weekly series hosted by me, Dr. Alan Scott, providing a rational, evidence-based perspective on important societal issues. Hello and welcome to another episode of The Rational View. I'm your host, Dr. Al Scott. On this episode, I'm welcoming Edgardo Sepulveda back to The Rational View to discuss the interactions between social inequality and COVID-19. Edgardo has co-authored a paper on the topic and he's come to discuss it on the program. As always, if you enjoy what you're hearing, please hit like on your podcast app, share it with your friends, and if you want to, come onto our Facebook group, The Rational View discussion group, and chat with us. Edgardo Sepulveda has been a telecommunications economist for 25 years, the last 15 with his consulting firm in Toronto, Canada. He was born in Chile and has an MA in economics. As part of his civic policy-related engagement, he also writes about electricity, inequality, COVID-19, and other issues, including at the Progressive Economics Forum. Edgardo has been the guest on a number of other energy-related podcasts, and today we're going to be talking about COVID-19. Edgardo, welcome back to The Rational View.
Thank you very much, Al. I thoroughly enjoyed our previous episode. I'm looking forward to this one as well.
I did as well. It's a rare honor to have a second shot at The Rational View, and it's a very small club. You and Chris Kiefer so far.
Happy to be in good company. Yeah, for sure.
So, a COVID-19 paper from an economist. How does an economist come to write about COVID-19?
Yeah, I mean, it's thanks for having me on again. This is one of my other kind of side gigs that I do, aside from my paying work, which is in telecommunications consulting. One of the other ones is energy, of course, which you had me on in a previous episode. But
one of my favorites.
Yeah, exactly. Yeah, and so. Basically, when the pandemic hit February, March of last year, the saying goes, it's a bit of a cliche, but, when the going gets tough, economists pull out the spreadsheets. And so that's exactly what I did. I was, things were slowing down for work for obvious reasons. My consulting was starting to slow down. And so I thought that it would be interesting to start to follow the whole pandemic and how it rolled out across different countries, how it was affecting different populations within countries, as a bit of a sort of ongoing social experiment, and wanted to understand what are the drivers and what were the risk factors. Basically, trying to look at this from the way that I learned as an economist is to study socioeconomic phenomena.
I see.
And so that was sort of my background. I had the time because I had the spare capacity, I had the bandwidth because things were slow. And so I joined a series of other, what I'm going to call honorary or amateur epidemiologists who kind of engaged in Twitter and trying to debate, sharing of spreadsheets, sharing of graphs, sharing analysis in real time with people around the world. And one of the ways that this got me interested in was kind of because I have a specialty in data analysis. I've been working with data and benchmarking and a series of other things in my professional work. I thought I could be of value. And so the first successful aspect of that was that I cold emailed a series of people working on long-term care facilities and the analysis of the risks and mortality associated with long-term care facilities in Canada and around the world, which, as you know, Al, was a very significant let's call it a very significant and sad event of last year, and
Indeed.
it's an ongoing issue. In Ontario and Quebec, here in provinces of Canada, we've had military intervention. The military have been called in to help out in long-term care facilities. A very sad process. And I wanted to understand this, and I wanted to kind of add to the knowledge base. So I emailed a series of specialists in the field and connected with two geriatricians out of Toronto, out of Mount Sinai here. And we co-wrote a piece on long-term care, and basically using the data analysis that I had put together, compared the mortality rates in Canada and put it in perspective of about 12 rich countries, the OECD, the Organization of Economic Cooperation and Development. And sure enough, from a relative perspective, and it's not a surprise to any Canadians who follow the news, Canada did particularly poorly. We really underperformed. And so that piece was published in about October or November of last year. I was a co-author, Samir Sinha and Nathan Stahl, who are geriatricians here at Mount Sinai in Toronto, were my co-authors. And then I wanted to go further. I wanted to understand beyond just an observation of, what things were, that is to say, description, and that piece was mostly a descriptive piece, basically confirming some of the things we knew, and also setting out other aspects. I wanted to understand why. Right. And, there's a difference between description and then understanding the underlying mechanism to explain, if there is an explanation, to explain these differences. Because yes, we did very poorly in Canada, but other countries didn't. And why was that? Is there something about our society? Was it a series of individual decisions? Were there systemic issues? Right. And that's one of the things that we do as social scientists, is using statistical inference. We try to understand whether there are underlying mechanisms that explain some of the differences across countries, or whether it's all just a series of random, personalized, specific, country-specific, where nothing can be explained anything, and everything is random, and everything's subject to national or geographic determinants.
I see.
So that's what we try to do. And at the time, already in Canada and elsewhere, people were talking about that, in spite of kind of like the saying, we're all in this together, people were saying we're not really all in this together, because we were seeing already that if there was a very, what is called a mortality gradient by age, that is to say that the difference between your risk of mortality, if you're say 15 to 45, is about 1/500th of what it is if you're 80 or plus. There's a very strong risk gradient by age. And that has to do with the strength of our immune system, that it weakens as a result of our age. And so therefore, COVID is much, much riskier for older people, given everything else, than it is for younger people. And we see that around the world. But we were also seeing, within age, we were seeing differences by income, by occupation, and by a series of other important determinants of health. And so we were seeing that in the United States, we were seeing in Canada, people of color, lower income neighborhoods, etc. And so I was interested in looking into that. And already in sort of June, July, and August of last year, people were talking about, what was the impact of inequality on COVID. People were noticing that at the time, the countries that tended to have high mortality rates. The US, the UK, Brazil, Mexico were countries that have traditionally been known to be relatively unequal countries, measured from like an income inequality. So already people were speculating in the summer of last year that this could be one way to explain the differences in performance with respect to COVID. One possible explanation was income inequality.
Your paper is about the interaction between social inequality and COVID-19 mortality, effectively. That seems to be the thesis that you are talking about. I understand how to measure number of deaths or mortality related to COVID-19, but how does one even measure social inequality to put up a graph, say?
We were measuring economic inequality, and which is a little different than social inequality. And the economic inequality, there's, economists have been working on these issues for hundreds of years. And it was probably about 50 or 60 years ago that an Italian economist by the name of Gini, last name Gini, Gini, thought of this mechanism, or this one single number that measured the distribution of income across the income scale. So it's basically the variable that we're measuring inequality is called the Gini Coefficient. And the Gini Coefficient varies from 0, which is perfect equality. So let's say in Canada's 38 million people, if everyone had exactly the same income, right? So if everyone had, I think the median income right now, let's call it $40,000. So if everyone in Canada had $40,000, every single person, the Gini Coefficient would be 0.
Okay. So it's measuring income or wealth?
Income. We also looked at wealth, but this is measuring income. And then if one person had all of the money in Canada and everyone else had zero money, the Gini Coefficient for that particular situation would be 1. So the Gini Coefficient varies from 0 to 1.
Okay.
And so, for example, low inequality countries such as, that we include in the sample would be Slovenia, Czech Republic, Norway, Finland. They're in the sort of between 0.25 and 0.3, so between 25 and 30. The high inequality countries, such as the US, the UK, Chile, Mexico, etc., they're sort of between 40, like 0.40 and 0.46. So those in the 40s. And then there's a bunch of countries that are in the 30s that are sort of medium inequality, and that includes Canada. Canada is about 0.31. So that's our, from a statistical perspective, that's our variable that we're trying to test whether or not, from a statistical perspective, that inequality is statistically significant and is a good explainer of mortality differences across countries. And so that's the statistical method, and that's a scientific method from a socioeconomic perspective.
So a low Gini is good.
A low Gini has lower inequality. Yeah.
Is more equal, less inequality. Correct. So I dream of a low Gini.
That's right. That's right. And so just in terms of background, I mean, and so after this piece was published on long-term care, I started gathering the data and trying to look at this from a scientific perspective, and with a view to actually getting it published. And as I mentioned, it was published just literally last week. It was accepted. We'll include it in the liner notes. But this is not. I mean, we certainly improved what I consider there are some novel aspects of the paper. But this is not the first paper, and it won't be the last paper looking either at inequality and health generally, and inequality and COVID. Right. So this is, as you know, Al, the scientific method. It's a series of building on top of to make sure that we understand in the literature whether or not there's a consensus around these these findings or whether there are outliers. I mean, this builds on a base of a number of papers and a literature that's been going on for 25 years. It was about 25 years ago that people started thinking about how sort of non-medical variables such as income, class, race, and other issues were affecting health. And people started hypothesizing that differences in income, for example, could affect health. And all of this kind of reached its sort of apex of policy relevance and discussion in a fairly well-known book called The Spirit Level, which you may have heard about. It's written by two English epidemiologists, Richard Wilkinson and Kate Pickett. Came out, I think, 2009, 2010, which was sort of the first thing that kind of popularized the idea that inequality is actually bad for societies from a public health perspective. And whether you look at, suicide rates, homicides, health, obesity, a series of variables, a series of health outcomes that they showed, or they wanted to show, that, the greater the inequality, the worst outcome that you had, whether it's on homicide rates, whether it's on obesity, whether it's on mortality, et cetera. Just to give you an example, Al, right now, if you look at the difference between life expectancy in Canada for the lowest income group in Canada, which is sort of the bottom 20%, that's in the range of the mid 70s, like 75, for example. But if you look at the life expectancy of the highest income group, it's about 7 or 8 years higher.
Sure. But that's just directly affluence, right? It's not necessarily inequality.
Well, this is the thing. This is exactly it. There are different explanations for these phenomena, and that's one of the things that we were trying to be able to disentangle, because ultimately these theories have to be tested empirically.
Yeah. Is the hypothesis that a society with significant inequality has a different effect than just a society with that number of poor people that are caused by inequality? Is there a difference between those two things?
That's exactly it. Yes. And this is you've hit it right on the nail, Al. The sort of much of the debate that goes that kind of has been going on in academics and practitioners who work in this area, and our piece will not resolve this issue because it's not an unresolvable issue, because it looks at a specific health outcome in a specific set of countries, but there are two camps. Right. And I want to kind of exaggerate them for a fact. One camp is what you're referring to, which is it really has to do with sort of the material differences, access to material differences from high income to lower income groups. Right, access to health, poor housing conditions, etc., overcrowding, and so that's one thing. And so, from a policy perspective, if we give greater weight to that, if we want to improve those outcomes, our focus should be on poverty. or on reducing poverty or on reducing lower income. Because if we can improve the material conditions of the low income groups, we will improve the health outcomes. So that's one kind of camp. It's obviously much more sophisticated than that, more complex than that. The other camp, and again, there's a mix of both. The other camp basically says, yes, I understand that, but there are other what's referred to in the field psychosocial variables that also affect health, and it's associated with that greater inequality tends to exacerbate social and psychological negative effects associated with social hierarchy, right? So the very idea that there's a very rich group of people and a very poor set of people in a society, in and of itself, the kinds of behaviors that kind of social hierarchy, the power relationships, the sort of conspicuous consumption associated with higher income people, leads to stress and anxiety and social climbing that are negatively affect health and therefore lead to poor health outcomes. And so we're not trying to solve which one of those two things they are. That's not what we're trying to do. But we obviously have to take this into account. What we also did in our paper was that we also included poverty or relative poverty as a potential explanatory variable in addition to inequality. So we took those into account because a lot of the previous papers had not taken poverty into account, and it had been critiqued because if you don't take both into account, you're possibly missing some of the key explanatory variables, and therefore you're kind of like your methodology would bias the results.
Yeah, indeed. That makes perfect sense. I would, coming into this, I would expect poverty would have a greater effect, and inequality as a secondary effect to psychological well-being would have a lesser effect. But that's just my hypothesis, and you're the man with the data. So what did you find?
Well, we found both of them to be important. Right. And this is sort of consistent with what others have found. We found that inequality without looking at poverty was important, and that when we take into account poverty, it's somewhat less important, but it's still statistically significant. So this is in addition to the literature, and it adds to literature, Al, because one of the things that I looked at it from an economics perspective, and I've done work on this, and we'll link to the show notes on material that I've written. I wrote my master's essay way back on inequality, and so I've always known and followed the literature that income inequality, has negative effects. Beyond, as you say, let's call it, your moral perspective on inequality, whether we personally like it or not. There have, over the last 20 years or so, there's been significant economic work done on whether inequality, beyond just our personal preferences as to whether we like it or not, whether or not it has an impact on economic performance, right? Does higher or lower inequality lead to lower or higher economic growth? What does it do with respect to education? What does it do with respect to tax avoidance and evasion? What does it do with respect to intergenerational mobility? So these are, as you said, this is our toolkit within economics, right? And these are well-established literature within the economic sphere looking at how income inequality affects a series of variables with respect to economic performance. What I'm doing here is I'm stepping outside of that purely economics perspective, but using the economics analysis and toolkit to look at how income inequality affects not necessarily economic variables, but health variables.
Okay. Yeah, sure.
And so that's sort of one of the additional things. And it's one of the reasons that I'm a co-author. Looking at this from the very beginning, I realized that I'm an economist. I'm not going to do this or understand some of the theory associated with the epidemiology component of this, which is why I got together with co-author and old friend and Sylvia Brooker, who's one of the co-authors, who's got a PhD in epidemiologist. So it's sort of in the best sort of tradition of multidisciplinary collaboration. We've got an economist and an epidemiologist looking together on an aspect that has both economic, public health, and epidemiological components that are key to understand, that probably cannot be understood well by one field or another. COVID is a complex economic, social, and health and political, phenomena that requires a cross or multidisciplinary set of people who know this material, or who can get to know the material using sort of the analytical background of their disciplines.
No, that seems like a great approach. So you found that there's a strong significance with poverty.
Yes.
And a slightly less strong significance with inequality. And were you able to? So you're trying to disentangle these effects, obviously, and you would assume that if there was a strong effect with respect to someone's income, that in a country with a certain average income, a higher inequality would have more people below a threshold where they're going to do poorly.
Yeah.
So that's teased out of you're not just correcting for the average affluence of a society, but you're correcting for the number of people in poverty in that country due to the inequality.
That's right. Yeah. So we run hundreds of regressions and looked at hundreds of different specifications to try to accurately fairly reflect what we understood the data to be telling us. And in our full model, which is sort of the one that we kind of focus on, we took a series of possible variables to understand. So just to go back to some of your earlier note about your earlier show with your colleague and friend on statistical inference, we want to make sure that we fully capture and isolate the effect that we're interested in. And so we have to make sure that we account for other, what we call confounding variables, right? To make sure that they're not telling us the wrong story, right?
Yes.
And so we have to. So in our full regression model, we if you think of it from a statistical regression, on the left hand side we had mortality rates across the countries, and what we did is to take into account, and this is one of sort of the novel aspects of the paper, is that to take into account that that there's this very steep mortality age gradient for COVID. Previous researchers had basically either not taken into account or had added a variable of, to try to take into account of the percentage of people over 65. What we did is a bit more sophisticated, which was that we ran different regressions for different age groups. So we ran one regression for the 15 to 45, another one for or 44, 45 to 65, 65, 79, and then 80 plus. So we ran 4 different regressions. And so for each regression, we looked at the mortality rate across the 22 countries, and we did include a fairly large sample of OECD countries, relatively equal, like sort of countries that are kind of referred to as the industrialized countries. Because the hypothesis basically says this, Al. The hypothesis says, we can't, we have to be able to look at the rich countries where poverty and low income is more of a relative measure rather than an absolute measure, compared to, say, a poverty in developing countries where poverty means destitution. That's not necessarily what we're referring to here in Canada or the other rich countries. So we're always measuring what we call relative poverty.
Okay.
Anyway, so what we took into account was we took the Gini coefficient, we took into account income, because we know that higher income tends to result in, among other things, better healthcare systems. And so therefore we wanted to take that into account. We also took into account relative poverty, as we've mentioned. And then we also wanted to try to understand or begin to understand what are the mechanisms that are driving this association between inequality and mortality.
Yes.
Because it's one thing to be able to just do a regression, right? And say, oh yeah, there's this correlation or causation or whatever, statistical regression, but we don't understand why, right? We don't understand why, right?
Yeah.
And so we try, so that's one of the other innovative parts that we try to incorporate in the very regression model. What are some of the possible pathways?
Okay. This is interesting.
Yeah. So one of the things that we did was, the theory is one of what they call, in terms of infectious diseases and just generally in what epidemiologists call the social determinants of health, which you may have heard about before, which is the idea that there are non-medical variables that impact on individual health and public health.
Sure.
So one of the things that people talk about is, well, if you think about the different stages of disease, you have what you call the exposure, you have the susceptibility, and then you have, treatment. So, from a COVID perspective is, are you exposed? Do you catch the virus? Second of all, are you of a different age, or do you have some comorbidities that once you conditional on being infected, what are your chances from a health outcome? Mm-hmm. And then the third component is access to health, right? Like, is there an ICU, for example, in the worst case scenario? Is there an ICU bed for you, right? Like, does the society have an ICU bed for you, or are you in a developing country where there's no ICU bed and you're in very bad situation? So we try to model those three components, explaining how it is that this association between inequality and mortality could be explained beyond just looking at it from a purely quantitative perspective. We wanted to kind of apply the theory of it and try to understand that. So we looked at three things. We looked at the availability of being able to work from home, right? So one of the things that everyone talked about is that people in managerial, consulting work were able to work from home, and a lot of service people were not able to work from home, mm-hmm. and had to go in, and therefore faced a higher probability of infection.
I see.
So that was one variable that we looked at. Another variable that we looked at was whether or not what percentage of people over 80 were in long-term care facilities.
Okay.
Right. So if there are, and there are big differences. There are social and economic very large differences between the way in which different countries deal with elder care, and whether or not there is an emphasis on aging at home, versus or with family versus being in a long-term care facility. The differences are, in some countries, the difference between the ratio of people in long-term care facilities and not is 3, 4, 5, 6 times the difference. Canada is one of the countries, from a comparative perspective, that has quite a number of people in long-term care facilities. And if we think that long-term care facilities, as we know, based on the past literature, were hotspots.
Yes.
Therefore, one of the reasons so the more people that you have in long-term care facilities as a proportion of your population, the more likely you are to be exposed.
Sure. Yeah, they did really poorly.
That's right. And we did very poorly. Long-term care facilities did very poorly across the world. So it just goes almost logical that the higher proportion of your population that is in long-term care homes will also drive mortality. And taking that factor into account actually strengthened our results on inequality, because without taking that factor into account, confounding factor, we weren't getting the same results. And the last part was what we call the survival rates, which is trying to take into account the sort of the susceptibility and access as a proxy. But anyway, so that's our full model. Try to take into account. There's more work to be done. Better granular data has to be taken into account. All of our data was based on group data. It wasn't on individual outcomes, because in terms of the quality of the data, very few countries, even now, are looking at data from a socioeconomic perspective. We know people's age, gender, sometimes race when they pass from COVID, but we usually don't know their income. Right. Mm-hmm. And so, or their educational attainment, et cetera, et cetera, et cetera. So, at this point, we're working at the population group level. We're not talking at the individual level. Right. We're looking at aggregate data, and there are some limitations associated with that. The interesting part is that this is an ongoing process, and as more data comes through, we'll be able to kind of dig into the data and come up with even stronger results, if they hold, more stronger predictive results. But one of the reasons I did this is, if we want to avoid the worst outcomes of a future pandemic, the policy prescription is clear, right? Is to reduce inequality. But that is one component. There are other components of why we think that inequality has negative effects on economic performance. And now the literature is suggesting that it also has negative performances with respect to pandemic performance. So yet another kind of like another in the ledger of the performance impacts of inequality is another one on the negative side that we can add to some of the others that have already been understood for decades.
So I've looked at your results, and I'm going to play a little bit of devil's advocate here, because obviously you've also seen my episode with Jeremy Balka on the statistics and the replication failures in the social sciences. Mm-hmm. And, one of the driving things of this are a lot of people publishing low significance results, which could come about through chance. And in your analysis, you've taken all these confounding variables and done regressions on each of them, I assume, and then you're fitting the residual to a Gini coefficient to find the residual correlation. And that means that your error bars get big. So what is the statistical significance of this result? Is it 3 sigma? Is it 5 sigma? How certain are you that the null hypothesis is ruled out in this case?
Right. Yeah. I mean, that's an excellent question. That's exactly the kind of exactly the kind of process that we had to go through. We went through 2 rounds of refereeing, one of which was a particularly aggressive statistician who asked us these very same set of questions. So we went through this process.
So you're prepared. This is good.
Well, yeah. I mean,
it wasn't me.
No. Yeah. We went through a peer review process of three referees. One of them was a generalist. I mean, we don't know. It was a double blind, right? So they don't know us. We didn't know them. And one of them was a generalist. One of them was a statistician, clearly. And then one of them was a theoretician, right? And they went at us pretty hard. And so the end result, and in a good way. I mean, this is a stronger piece as a result of it. And so we actually, as a result of both of their comments from the theoretician and from the statistician, we changed our model and we scaled back from our earlier much stronger language and much more definitive models to the most conservative model possible. And so what you're seeing here is the most robust conservative estimate. The earlier drafts had much stronger models, but am I convinced? Yes, I am convinced, because we went through this very robust peer review process. We use relatively sophisticated statistical methods, and we ran, there's a whole, what's it called? I guess it's section 3.1, which is called Robustness, Sensitivities, and Limitations, where we kind of go through the process and probably ran hundreds of regressions to make sure that our results were robust, that we were using the most conservative and replicable models possible. And that we were taking into account all those processes associated with some of the problems associated with time series cross-sectional data. So, without getting too technical, there's the whole idea of correlation, right, where one period is associated with the other. There's a problem of skedasticity, which is that when you look at cross-sectional data, the errors are not always uniform. A series of data processes. And so what we're presenting and what ultimately was accepted was a highly conservative, extremely robust specification that still ended up with significance for the main variable, which is the Gini coefficient, from 0.1, a p of 0.1 to 1%, and for some of the older age groups at 10%. So that's ultimately our results. And yeah, I'm quite confident, given the 4-month process that we went through in terms of peer review, made it a much stronger, a more solid piece that compared to the earlier ones where we kind of overreached a bit, we kind of scaled it down and kind of focused on what we considered to be the core, most conservative, most robust specification, which still produced the kinds of results that are worthy of publication.
Excellent. And that, it's a difficult process to get any paper through peer review to get it published, because you should be challenged and you should be forced to look at all these things, and then they always make you go back to the drawing board and work through it.
Indeed, yes. No. We literally went to not quite a drawing board, but yeah, close.
I think this is interesting to discover, to try to tease out some of the factors that influence health responses in populations, and one definitely would expect poverty to be a driver in outcomes, and maybe it's more surprising that inequality on its own is a driver, but maybe not when you consider the psychology of unequal society. If you feel like you are doing well amongst your peers, you have less stress than if you feel like you are falling behind a visible peer group.
Well, that's right. I mean, you think about the political explanations of the rise of Trump, for example, in the United States. A lot of it has to do with this the political explanation is this feeling of falling behind, right? Whether or not your sort of objective material reality may or may not be different, or it's actually in the grand scheme of things not that bad, but the feeling of falling behind leads to all kinds of negative political, social, and health outcomes. So it's an interesting insight that I found interesting. Again, we're not trying to say that is what is explaining this. But what we're saying is that, we're not rejecting it either. It could be a combination of that, or the differences in objective material access, right? In terms of the idea of crowded housing, having to, not having a car and therefore having to deal with transit during a pandemic, all those kinds of things. We're not exactly sure. And things will change as the pandemic wears on. Vaccination is going to be an important aspect as well. All of our data of the studies that have come out. Our data set was the longest period. We had 9 months of data. A lot of the other researchers had 3 or 4 months, or some even had weeks. We had 9 months of data, and we made sure that we stopped our data collection before vaccination took into account. So all of this is pre-vaccination, so that you're making sure that you're not commingling the effect of vaccination on the actual effect of mortality.
I think another important correlation with COVID and inequality that we're seeing right now, and we're going to feel the effects of in a much stronger way, is the mass exodus of women from the workforce to provide home care to their children. This is, I think, really kicked back a lot of our progress in inequality quite a ways. It seems like the impact has fallen very unequally, and mainly back into traditional roles in childcare and work. Have you noticed anything of that? Do you have data on anything like that? Have you looked at it?
Yeah, I mean, a series of economists here in Canada and elsewhere have kind of talked about, I think the buzzword is a she-cession. That is to say that that the effects of this the societal response to COVID has fallen disproportionately on women. And so I have seen some of that. We'll see how much of that, once the pandemic goes away, fingers crossed, whether that persists and what are the long-term effects of that. So we didn't look at in our study, we didn't look at any behavioral responses to COVID. All of our data is like historical pre-pandemic data. So it's all driven by structural causes. So, for example, I know a lot of people looked at, what were the, how did public health effects like the lockdown, mask mandates, et cetera, how that affected mortality. We didn't do that, right? Because we didn't take that into account.
Sure.
We didn't take into account any behavioral events. All of our were pre-pandemic historical debate. Because one of the things that, as you'll probably know from your other episode and any kind of statistical, is that when you throw in contemporaneous variables into any kind of statistical method, you start to have to deal with endogeneity, right? Which is the idea that what is driving what? Is mortality driving public health responses, or is public health responses driving mortality, right? For example, a lot of people talked about how stronger public health measures tended to be associated with high mortality, but So, and we're drawing the wrong conclusion that public health measures led to mortality, when in fact it was a response to mortality.
Yes.
That is that a bigger, stronger mortality effect in countries led to stronger public health measures, not the other way around. But that is in and of itself a measurement issue that's right. It's endogeneity. It's all, one leading to another, and you don't know. So anyway, we want to avoid that, and all of our data, so all our work from home data, our long-term care, all of our data is historical, that is impacting the effect of mortality. But the important thing is this. I mean, one of the strengths of this and other literature that came out is that, the public health measures, lockdowns, mask mandates, etc., we didn't even have to take into account, and we still were able to explain mortality to a great extent.
It's surprising that there is an effect that holds up after all of those different approaches. And you have to average so much to get there.
That's right. You have to do that. But in the end, what you're trying to understand, and by the way, the other thing I'm going to do, Al, is I'm going to link to a story that came out last month in The Economist magazine, conservative magazine that usually doesn't talk about inequality, but basically covered this specific topic and cited some of the papers that had previously come out that we had used as part of our literature review. Too bad our paper only just got out, so we couldn't have get cited in The Economist. But they go through the idea that, is there one thing, or is there a number of things that kind of like, when you take all of these issues into account and the thousands of individual decisions at the public health, political, mass mandates, school closings, when you take all those small little individual things into account, but beyond that, you're dealing with bigger structural issues that drive health. And that's one of the things we're trying to do. We're not trying to answer that this matters every single time and all the time. But what we're saying is that when you even can ignore public health issues and all those other things, not that they're not important, but you take those into account, what we're saying is that after all of that, across 22 countries, across different age groups, across different income strata, taking into account poverty and all of these other issues, inequality still matters. Mm-hmm. And so that is not an insignificant finding, that there are structural things that we can kind of mess around at the margins with public health measures, but there's some systemic issues that are going to show and come to the forefront when you get this kind of shock. So you have the structure of the way in which society's structured, and then you shock that, and what you're going to get is the same result, more or less, regardless of what you can do to kind of band-aid it on top, because you have these deep structural issues, whether it's gender, whether it's income, whether it's race. We focus on income inequality. And so, we were pleased with the findings. It's pleased from a scientific perspective. It's not a great finding because, in a sense, some of these deaths were preventable from a structural perspective. Had we had lower inequality, what our model basically says is that we would have had lower mortality.
Mm-hmm, mm-hmm. And that's an important result. I mean, I'm on board with you that social inequality is something that we need to break down. It's been growing. If you've listened to my income inequality podcast, one of my earlier ones, where I looked at this and I analyzed this, it's been growing since the 70s, and it's right now at the highest point it's ever been in over 100 years in North American society, at least. I think it's something that definitely is leading to Trump. It's leading to breakdown of democracy. It's leading to a lot of unrest. I mean, this is where societies fall apart at this level of inequality. So good to be able to highlight this, and it's worthwhile to bring up another potential downside to social inequality if you need more to address it. I'm not sure if this is what we what we need to address it. We should be addressing it anyways.
Yeah, as if we needed another reason. This is another one. Yeah, for sure.
So I think we're getting towards the end of our time scale here, and it's been great talking to you again, Edgardo. I had a lot of fun digging through your paper with you, and definitely impressed with the breadth of your work. Electricity and COVID. What's next for you?
Well, I mean, if things go well, this is an international work. I want to do some more Canada-specific work on social determinants of health, looking at inequality, looking at, in the same way that you can look at this across countries, you can also kind of look at it across provinces. And so, yeah. Oh, by the way, and before I head off, I wanted to also, I gave a shout out to my co-author, Anne Sylvia Brooker, but we received some great statistical and technical assistance from a PhD economics student at my old alma mater at Queen's University, Daniel Teeter, who helped us out with the relatively sophisticated and robust statistical methodology and actual number crunching that I didn't want to have to learn my econometrics or relearn my econometrics from 25 years ago. So it was a truly team effort. Again, I want to make sure that I gave credit to both Anne Sylvia and to Daniel for helping put out this piece that I'm very pleased to be able to talk to you about, Al.
Oh, thank you very much. And I'm starting a new thing for my guests. I'm going to be sending everybody a T-shirt for coming on the show. So I'll be firing off a Rational View T-shirt to you. And thanks for spending the time to come on the show, Edgardo.
Oh, excellent. I was just going to ask you about that T-shirt and how I could get one. Now you've answered my question.
Yeah.
Great. Thanks again, Al. Looking forward to wearing it. I'll send you my size. And then again, thank you again for the second invite. I enjoyed this and looking forward to some more.
Appreciate it very much. Thank you.